Hi, everyone. My name's Amelia. I'm a third-year resident at Full Circle, Family Medicine Residency in Boise. Thanks for joining my talk today. I don't know if I'm going to reveal or teach anything revolutionary, but it's just going to be a good review of some of the most common ophthalmologic pathologies that you might encounter in your primary care practice and a review of the current evidence. Okay, here is the disclosure statement. So, my objectives in this talk are to review common eye diseases that you may encounter among your panel, and then again review evidence from standard ophthalmologic practices across the lifetime. And so, going to chunk up the presentation into 3 different chapters. So focusing on uh, a few issues with eyes in the newborn to pediatric population. And then the second one will be kind of the adult age range. And then the third one will be geriatric patients. And then also going to review associations between chronic diseases and specific ophthalmologic disease. Why this is important, as all of you know, primary care doctors will frequently be the first touch point for eye concerns. If not the clinic, then the ER or urgent care. And then certainly comprehensive knowledge of the pathophysiology of eye disease or how eye disease works and why certain conditions happen is important for for us to be able to counsel and provide anticipatory guidance for patients with specific chronic disease that puts them at higher risk for different eye diseases in the future. I think for me, this was an interest for me because I feel like throughout medical school and residency, I've gotten very little training in ophthalmology. But I oftentimes will take care of patients and refill eye drops and different medicines related to chronic eye disease for patients on my panel. And so this was an opportunity for me to educate myself as well. And then this impacts one of AHEC's core topics by the practice transformation pillar. Okay, so digging in, we're going to start with the newborn to pediatric age chapter. And we're going to go through 4 different common pathologies encountered in this age range. First, we'll start off with the evidence behind erythromycin ointment, which is the common eye cream that's applied to babies' eyes at the time of delivery. Then we'll talk about dacrostenosis, conjunctivitis, and amblyopia. So evidence for erythromycin, this is one of the 3 common newborn meds that all newborns are offered at the time of delivery: erythromycin, vitamin K shot, and the hepatitis B vaccine. It was interesting for me to kind of dig into this evidence. And so really the erythromycin cream is applied to eyes at birth for the prevention of what's called ophthalmia neonatorum. It's this fancy Latin phrase to describe a disease that was first noted in the 1800s by a physician that noted a large percentage of his patients were going blind, later on to realize that it was primarily caused by gonorrhea infection of the eyes. And so ophthalmia neonatorum refers to conjunctivitis of the eyeball in the first month of life. And gonorrhea and chlamydia are the 2 big ones that we're concerned about. There's other bacteria that can cause conjunctivitis, but in the first month of life, if a baby has symptoms consistent with conjunctivitis, we worry about gonorrhea or chlamydia. So that's why all newborns, the CDC has recommended all newborns get erythromycin ointment applied to their eyes at birth to reduce the risk of blindness from the infection. Some evidence suggests that this ointment may also, certainly also does reduce overall bacteria load in the eye and may be helpful to prevent conjunctivitis from non-sexually transmitted bacteria like Staphylococcus aureus. Um, and erythromycin prophylaxis may be helpful if the mom and or her partner did not receive adequate screening or treatment for gonorrhea during the pregnancy, and it's not possible for mom at the time of it's not possible to test mom at the time of birth and treat the infant as needed. And so these are kind of a few recommendations or considerations to have in mind for talking about the pros and the cons and the risks and benefits and the utility of erythromycin ointment with your patients. Is that it may be there may be a greater it may convey a greater advantage to a different demographic depending on who makes up your patient panel. So it's an individual decision. Erythromycin prophylaxis may help protect a newborn from the gonorrheal ophthalmia neonatorum if the mom was infected after a negative screening result earlier in the pregnancy, if there was infidelity happening, or if they're in an open relationship. And so certainly we always screen moms in those prenatal labs for gonorrhea and chlamydia, but that's typically in the first trimester. And then you may or may not screen again in the third trimester, depending on what your practice is. But again, that could potentially be an entire 6-month period where that patient might have had the opportunity to become reinfected. There are some adverse effects of the ointment that have been documented, including chemical irritation or blurry vision. I really don't know how they uh, studied blurry vision as a side effect in a newborn. Um, and then erythromycin ointment is increasingly less effective in preventing gonorrhea because of breeding resistance. And so it did, in this study, it did have a 20% failure rate in the past. Alternative options that you may hear patients ask about, or you may see offered in your practice or in someone else's practice, are antiseptic solution like iodine, the watch and wait approach, or using colostrum instead of erythromycin ointment at birth. Um, so a couple takeaways as primary care physicians about erythromycin ointment. I love this website. It's called Evidence Based Birth. If you haven't had a chance to check it out, I really recommend it. This uh, handout on the side here that I have a picture of is free, and you can print it off and give it to all of your patients for free. That's okay with Rebecca Decker, the provider who has created this website. And so I recommend printing this out and then actually giving it to all of your patients. If you do prenatal care, you can give it to them in their late in their third trimester or in their prenatal packet, whatever your routine is. But this worksheet goes through all of the evidence behind newborn eye ointment in a really clear way. So again, erythromycin ointment may offer some protection against less serious types of newborn pink eye um, uh, from different bacteria picked up in the hospital or in the environment, like Staph aureus. And then it may be helpful to consider for patients if they are at risk for having contracting gonorrhea later in their pregnancy after a negative screening test earlier on. Okay, second diagnosis in the little ones for eye concerns is dacrostenosis. This refers to a blocked tear duct. There's many causes. It can be congenital or acquired. The lacrimal duct, which is in your upper eyelid on the outside, produces tears. And then the nasolacrimal duct, which is the punctate uh, spot, kind of where you see this yellow goopy discharge in this kiddo's right eye, that's what drains the tears. And so your lacrimal duct constantly produces tears to lubricate and moisten the eye, and then it will drain through the eye duct. But dacrostenosis is a disease of uh, blocked tear duct, and the symptoms that you can have from it are persistent tearing and ocular discharge. It oftentimes can be confused with conjunctivitis because of the yellow mucousy appearing discharge. But a way to distinguish dacrostenosis and conjunctivitis caused by bacteria or virus is that oftentimes in dacrostenosis, the conjunctiva themselves will not be injected. Um, Red and the spidery vessel appearance of the conjunctiva in conjunctivitis, you won't have that in dacrostenosis. So you just have the goopy yellow discharge. Um, I thought this was interesting. I don't know where I missed learning this in medical school and residency, but I did not know until I was preparing for this presentation that babies don't make tears until they're 2 weeks old. So this problem doesn't manifest until babies are greater than 2 weeks old, because at 2 weeks is when they start producing tears. And then tear production will gradually increase through 1 to 3 months of their lives. So really, in the first 2 weeks, if you have any eye goop, you're worried about conjunctivitis caused by bacteria. The big scary one is gonorrhea that can lead to blindness. And then other scary ones that are also important are chlamydia and other bacteria. So common treatment for dacrostenosis, warm washcloths applied to the eye, and then you can do massage to open the tear duct. And then very rarely does the child require surgery to probe the duct open. This disease can be unilateral or bilateral and recurrent or intermittent, so not very helpful distinguishing clinical manifestations for history taking. This is a good picture of the anatomy of the lacrimal gland, producing tears, and then coming down into the eyes, sweeping across the conjunctiva and the cornea, and then outflowing through the lacrimal duct. This other picture is kind of blurry, but it talks about technique of the lacrimal massage, which suggests that you apply steady pressure at the inner canthus and then downward traction towards the nose to open up the nasolacrimal duct. Okay, last pediatric eye concern, conjunctivitis. Um, This is a tough one, and I don't have any groundbreaking evidence or recommendations. But just to review, majority of cases of conjunctivitis are caused by viral etiologies rather than bacterial. We're trained to be very cautious about antibiotic prescription for conjunctivitis because the majority of the time it's caused by a virus, and the symptoms will be self-limiting, and antibiotic treatment isn't necessary and maybe carries the risk of breeding antibiotic resistance. I think a couple helpful key pearls in this is that age matters. And so, certainly under 1 month of age, we worry about transmitted etiologies of conjunctivitis like chlamydia and gonorrhea. Versus greater than 1 month of life, we can start thinking about dacrostenosis and then other bacterial, more benign bacteria and virus, like adenovirus is the most common cause of viral conjunctivitis. One way to distinguish bacterial versus viral is often that you'll have a viral prodrome. That's URI symptoms with nasal congestion, watery, itchy eyes, a headache, fatigue, things like that. And bacterial, oftentimes, you might have concurrent otitis media, and so important to look in their ears, especially in the pediatric population. Anytime someone has a eye goop concern or eye discharge concern, take a peek in their ears. And then if they do have signs of otitis media, by looking at their TMs, you could consider treating them um, with a topical or eye drop cream or eye drop. Oftentimes, allergic conjunctivitis will present with watery, itchy eyes, and then some red flags anytime someone has an eye concern. If they have painful eyes, photophobia, persistent vision changes, anisocoria or corneal abnormalities, you want to get them plugged into ophthalmology as quick as possible to be able to conduct a dilated eye exam. The most recent Cochrane review about conjunctivitis was updated in 2022. They found through a review of the literature that using antibiotics was associated with a modestly improved chance of resolution of symptoms in comparison with placebo. And they found that antibiotics likely increased clinical cure and microbiologic cure by doing swabs of the eyes before and after treatment, after a course of treatment in comparison with the placebo. They recommended considering more research about the effect of antiseptic treatment, like an iodine solution, given growing antibiotic resistance. And then found this really interesting. They found that overall, they found spontaneous resolution happened at day 4 to 9 in the placebo group, and that occurred at a higher rate in the placebo group versus the antibiotic group. So in the placebo group, people had spontaneous resolution at uh, what am I trying to say? Oh, I think this is actually. Oh, yeah. I guess what I was trying to say is that the rate of spontaneous resolution is um, quite similar, 55 versus 68% of the time. So antibiotics didn't bump up the recovery time that much. Certainly, we face a lot of social pressure as primary care physicians from parents and schools and employers. And so oftentimes kids will need a prescription to be able to return to school. Um, and then the most common bacteria that causes bacterial conjunctivitis in pediatric patients is Haemophilus influenza. For adults, it's Staph aureus. These are a couple pictures. The first set of 3 pictures are examples of bacterial conjunctivitis. You can see the mucopurulent discharge and then the injected conjunctiva. The middle picture is an example of viral conjunctivitis, which may appear similar to the picture on the far right. But the middle picture is an example of unilateral conjunctivitis with increased tearing without any evidence of discharge. And then the far picture is allergic conjunctivitis, which is showing bilateral injected conjunctiva. So PCP takeaway for conjunctivitis: age is a helpful clue. I found this finding interesting. They found that 71% of conjunctivitis cases in children are bacterial causes versus 78% of cases in adults are viral. And that's from a really recent AFP article about conjunctivitis this year. Contact lens wearers should always be treated with antibiotics and encouraged to discard of their contacts and not wear them until treatment's complete. Important to know your red flags for any eye concern and know when to emergently refer them to ophthalmology. And then important also to counsel on reducing transmission with vigorous hand hygiene, as you all know. This is an example of anisocoria where you see the diameter of the pupil. The black part of the eye is different in both of these photos. This is an ophthalmologic urgency and requires immediate evaluation by someone that can do, again, an exam of a dilated eye to be able to properly and thoroughly visualize the fundus of the eye. Okay, Maybe I lied. Maybe this is the last eye concern for the pediatric chapter. Okay, so amblyopia, also known as lazy eye. This is a neurodevelopmental disorder that arises from abnormal processing of visual images that leads to a functional reduction of visual acuity. It is the leading cause of childhood monocular one eye vision loss and can be responsible to up to 3% of permanent vision loss in adults. It's typically unilateral, as evident as an example. This first photo, it can be bilateral. And then on the bottom here, you see a kiddo wearing glasses and then a patch, which we'll talk about in a second. So the evidence for amblyopia, there's multiple treatment strategies, patching versus using eye drops to blur vision in the non-amblyopic eye. Um, and a Cochrane review in 2019 found no difference between the two treatment options, including patching versus eye drops. So the eye drops work, they're typically atropine eye drops, and they block the parasympathetic innervation of some of the eye muscles in the pupil, and they lead to pupillary dilation. Because of that, so you put eye drops in the good eye, and then by blurring the good eye, you force the bad eye to um, establish more eyeball brain neural connections and uh, hone the acuity of the bad eye by forcing it to work harder. Um, and for the patch, I found this interesting. There was a recent AFP article that reporting that patching 1 to 2 hours a day led to similar results as patching 6 hours a day. So this would be a good option for a child that maybe doesn't want to patch or has some anxiety around patching at school for fear of being bullied or appearing different. And so if you wanted to just patch at home, they have to be awake, obviously, while you're doing the patching. Um, and then the younger the condition is detected, the more beneficial the results. So, treatment of amblyopia under 7 years is when we find the most uh, improvement in their visual acuity that is permanent. So, takeaways for primary care doctors. This picture is a picture of foils. And so her right lens is foiled or blurred. And then the left lens is not blurred. So we would blur the good eye, and then we would fix or correct the vision in the left eye. So important to take a thorough history and exam, certainly. And I think particularly things to think about. This is particularly why it's important to ask parents if during newborn visits and in less than 1 year while child checks, is your child tracking you across the room? And what happens when those eyeballs move to watch mom or dad walk across the room? And you can certainly assess that in the clinic by just laying the baby down on the table and moving from one side to the next. Um, and then there's different causes of amblyopia. One of them can be refractory. And one way to assess that is to make sure that you're doing a proper red light reflex um, by dimming the lights in the room and assessing both of the red light reflexes in both of the eyes and making sure that what you're seeing is an equivalent uh, image in your ophthalmoscope. There's a really neat app. It's called Go Check Kids. It's not free, and your institution does have to pay for it to subscribe. I tried to download it, but it can essentially what it does is it takes a picture using the flash on your camera on your phone of a child's eyeballs, and then it will assess the refractory index in both of the eyes and compare them and evaluate whether or not they are at risk for amblyopia. Okay, moving on to chapter 2, the adult, we'll talk about three things. Myopia. I don't actually know if I'm saying that right, if it's myopia or myopia, but myopia, pterygium, and then diabetic retinopathy. Okay, so myopia or nearsightedness. This is a common condition. Essentially, if you need glasses or corrective lenses or corrective contacts, you are a myopic person or a nearsighted person. The physiology of this is that the eye is too long, and so the axillary diameter of the eye from the cornea to the retina, so that length is too long, and the images are focused at a point in front of the retina. Ideally, we would have that image come and the focal point would correspond with the retina, but in a myopic person, the focal point lands before the retina, and because of this, myopic people like myself have a hard time seeing far away, but are able to see up close just fine. It was interesting to learn about the causes of this. It's suspected to be multifactorial, environmental and genetic factors leading to progressive axial elongation. But one of the biggest risk factors that they have found is that the more the more time that children spend doing near work, which is to say, the more time they spend focusing their eyes on something up close, the more at risk they are for myopia in the future. And so, uh, one of the treatments for an early identified myopia is to spend more time outside. And so the thought is that if you spend more time outside, you'll spend more time looking far away. And then they also found that the impact of UV light, children exposed to UV light to a greater degree are at lower risk for myopia. So certainly there's risks and benefits to spending time less reading and spending time outside with UV light exposure, but just an interesting thing to think about. Certainly, we know about different treatments, glasses, contacts, surgery. LASIK surgery is probably a common thing you may encounter in your clinic. But essentially, what that surgery does is it decreases the curvature of the cornea by removing tissue from the center, and then moves the focal point back from in front of the retina to the exact center of the retina, resulting in 20/20 vision. Pterygium is the second eye concern for adults that is a commonly encountered thing. Pterygium is this pink fibrovascular lesion that you can see on the nasal edge of this eye. It's a fibrovascular degeneration of the conjunctiva that over time can grow and advance across the cornea. There's lots of risk factors for this, the biggest one being UV light exposure and increasing age. Um, this can be a benign process until it begins to impact visual acuity and eyesight, and there is no topical treatment for it that is FDA approved at the moment, but surgery can happen to remove it, and you can prevent further pterygium from occurring by uh, using UV light blocking glasses. So takeaways for the primary care doc, important to assess, important to wear glasses outside when you're exposed to UV light to prevent pterygium from occurring in the first place, and then important to know what they look like so you can recognize them in your patients and know when they need a referral to ophthalmology. Diabetic retinopathy, the last adult concern, something that we're all very familiar with. These are just good pictures of what you may see if you look at the back of the eyeball in a diabetic patient. Very hard to do a proper fundoscopic exam and to be able to analyze this. So oftentimes we will refer our patients out to do exam under dilation to be able to properly visualize the back of the eyeball. So the pathogenesis of this is that high sugar levels and inflammation caused by uncontrolled diabetes. type 1 or type 2, can lead to local tissue hypoxia, which triggers elevated levels of this fancy growth factor called VEGF, leading to more blood vessel formation or angiogenesis, which can lead to hemorrhage and vision loss, essentially. There's two different types of diabetic diabetic retinopathy, excuse me, non-proliferative and proliferative. Proliferative is a bad type. There's a few things you can do to treat this. Certainly, we would want to prevent it in the first place by making sure that our diabetic patients have their A1C under control, but we do our best. The first treatment is an eyeball shot with this medicine called anti-VEGF. It's a monthly injection that they shoot into your eyeball. And then if that doesn't work, then a surgery called a vitrectomy, where it's kind of demonstrated in this photo. They stick a probe into the middle of the eyeball and then suck out the hemorrhage and then replace it with another material. Some risk factors for developing the bad type of diabetic retinopathy include age of diagnosis, higher triglyceride level, higher A1C, and then renal impairment. Takeaways for us, I think education is the most important thing, something that I'm hoping to do a better job of in my future career is spending more time educating my patients on all of the organ systems that diabetes impacts, and just being aggressive about reviewing that at every visit, and considering using the teach back method to make sure that you're on the same page with your patient and they understand the importance of why you're recommending that they get an eye exam every year. The last chapter will be the older adult. We'll review 3 common conditions: cataracts, glaucoma, and dry eyes. Oh, you know what? I think I lied. I don't think I included dry eyes on this, just cataracts and glaucoma. Cataracts, this is a disease. You can see the cataract is in the right eye of this patient on the top. It's no opacification of the lens. There's many different risk factors: diabetes, genetics, UV light exposure. And then other than environmental and medical and biologic risk factors, it can also be congenitally acquired. And so different perinatally or peripartum exposures can lead to congenital cataracts. Oftentimes it's something that the fetus is exposed to in utero. So rubella, CMV, varicella, herpes, alcohol, and then some genetic conditions like Charge syndrome and trisomy 13, 18, and 21. This has to be recognized immediately and treated immediately before the baby's permanent vision is affected. And so surgery has to happen for congenital cataracts within 6 to 10 weeks after birth. And so again, another reminder of why it's so important to dim those lights before you do your red light reflex and do a really, really good exam. If you can't get it, you can try tactics like bringing the baby from horizontal to vertical position to trigger a reflex that causes them to open their eyes. Glaucoma is a progressive deterioration of the optic nerve resulting in vision loss. It's multifactorial. One of the risk factors for glaucoma is elevated intraocular pressure and an elevated cup to disc ratio. You test for interocular pressure by, if anyone has had it done before, it's a little exam where they shoot a burst of pressure into your eye and then it records the pressure in your eye in millimeters mercury. And the only way to treat glaucoma is to reduce the only way they've found to treat it is to reduce ocular pressure to slow or stop progressive vision loss. Ocular pressure is determined by the inflow and the outflow of the aqueous humor production. And it varies throughout the day. Um, the pathogenesis of this is only partially understood because, again, while increased intraocular pressure is a risk factor, not everyone that has elevated IOP develops glaucoma. And then people of African and Hispanic descent in the US have at least a threefold higher risk of developing glaucoma than non-Latino white people. And then again, glaucoma is second only to cataracts as the top cause of blindness and the leading cause of blindness among people of African descent in the United States. Here are some risk factors associated with glaucoma: diabetes, lupus, rheumatoid arthritis, migraine. I thought that was interesting. Sleep apnea, and sickle cell disease. On the right is a picture of a fundoscopic exam of somebody with glaucoma, and on the left is a uh, normal fundoscopic exam. What you're supposed to be able to see is on the right is an increased cup to disc ratio, and then they refer to it as notching at 6 o'clock, which I believe is where the red vessel starts to blur at the bottom. So evidence for glaucoma treatment. Oftentimes patients will be on eye drops. There's lots of different types. Prostaglandin analogs that end in prost, beta blockers like timolol, carbonic anhydrase inhibitors, parasympathomimetic agents, pilocarpine. All of them work to decrease intraocular pressure either by reducing the production of aqueous humor or dilating the outflow tract where aqueous humor leaves. The light trial looked at two different therapies to treat glaucoma: laser trabeculoplasty, which is a laser procedure, versus eye drops. They found that folks that undergo the laser procedure, 75% of them required no additional treatment over the next 3 years. And the way that it works is it reduces resistance to aqueous flow. And so it allows more aqueous humor to go out of the eyeball to reduce the pressure. Certainly one of the complications of treating a condition with eye drops is adherence. And there's no evidence to screen the general population for glaucoma because there's no demonstrated benefit of screening for vision-related quality of life or function. Acute closure glaucoma is an ophthalmologic emergency and differs from primary open-angle glaucoma, which is what I was just talking about, in that clinically the onset is immediate, acute, and patients will experience blurred vision, headache, nausea, unilateral eye pain. It can have acute or chronic causes. Acute causes are oftentimes medicines, which are listed on the right, and there's a bajillion of them that we use every day, which is kind of scary. And then chronic causes can be due to deposition of infiltrates or what's called neovascularization of the anterior chamber, just more creation of small capillaries in the eyeball. Let's see. Oh, and then medications for acute closure glaucoma for patients without access to immediate ophthalmologic care for people that practice in rural areas is IV acetazolamide or topical timolol. Okay, that is the end of my presentation. I would love to hear from you all. Thank you for listening. I really appreciate it. If you have any comments or questions or wisdom to share about common eye complaints seen in your practice, I'd love to hear them. Otherwise, thank you for listening. Oh, I guess I didn't show you my sources slide. It's on there.
I guess one thing for us, and I work in corrections, it would be so nice to have like a walk-in clinic, like the optometrist. I hate sending them to the ED, but
Oh,
like I don't always have someone on site that can do a slit lamp exam.
mm.
So I don't know if there's one in Boise, but that I think is the hardest thing is recognizing it's kind of outside your realm,
Totally.
but not sending them to the ED.
Totally. Yeah, yeah. To look for, like, a corneal abrasion or anything like that. Yeah, yeah. Yeah, and, I did read an interesting article just kind of advocating for primary care physicians to get specialized training in split light exams, because we just don't get that kind of training, in our careers, and so, I don't know what that would look like or if that would be a possibility to spend some time doing some training to acquire that skill or if you even have the resources to do that, but that's yeah, I can't think of a clinic where we could send patients urgently here in Boise. um I would probably, I mean, I've sent them to the ER before, so which is kind of funny that ER physicians get so much good eyeball training and eyeball exam skills, but I don't have any magic answers. Okay, well, any other questions or thoughts? Otherwise, thank you so much and have a great